Incoming.
Nobody hit Abby in the head.
All right. So let's relax for breast disease. So I don't know how much of this is going to be reviewed from what you had from PD lab in terms of PD lab lecture. They're getting a little rowdy. Doing just a heart failure review. All right. So some of this might be review, but we'll kind of skim through this first part real quickly just to kind of hit the highlights. And then we'll be talking lots and lots about breast disease. So it's kind of everything we're going to be talking about today. So when we talk about social issues in terms of women, just to understand that certainly a woman's breast tissue, even a man's breast tissue, really kind of helps define their sexuality, who they are. For women, it helps to define your womanhood, so to speak. So certainly when we talk to them about biopsies and mammograms and self-breast exams, just kind of, keep in the back of the mind that you're talking about part of their sexual being as well. When we talk, we're concerned for basically breast cancer for these women. So we basically want to make sure that, and certainly there's lots of issues with regards to the breast that are very, very benign and very, very common. So it certainly can make looking at these women difficult. We talk about the histology of the breast tissue. We've got, gosh, they're loud. Tell them to pipe down. Snap your finger, that's what I normally do. What did he say? So we got we've got multiple lobes within the breast. Within each lobe, we've got groups of lobulates, and we've got ductal tissue there. And certainly the whole point of the tissue is to facilitate milk production over time. But certainly that breast tissue changes over the course of a woman's life. When she's very young and kind of in her 20s, the breast tissue is much firmer. There's much more of a muscular component to it. As we age, and certainly as women breastfeed, a lot of it gets replaced by fatty tissue, so the density of the breast becomes different over the lifetime. Basically, when we talk about 80 to 85% of the normal breast tissue is going to be fat. Okay, so there's some ductal tissue there, obviously lymphatic drainage is there, a little bit of muscular tissue, but we talk about the ligamentous structures that are holding the breast up. Okay, it's driving me crazy. We talk about Cooper's ligament. So Cooper's ligament is the ligament that basically, for lack of a better word, kind of holds the breast tissue up and perky. And as we age, we get a little bit of laxity to that tissue. So whenever you have talked to a woman about having a breast lift, typically what they've done is they've suspended Cooper's ligament and they've actually pulled that area taut. One area that women oftentimes forget to actually examine, and hopefully we don't forget to examine it as clinicians, is the talus fence. So that's the tissue that's going to go up into the axilla. You actually get breast cancer up in that area. So it behooves you to not only look at the breast tissue itself, but really follow that tissue as it goes into the axillary region. So we go through many changes. Basically, that pre-menstrual phase, we have kind of increased breast tissue formation. Certainly, we're going to go through this Tanner staging. We have pregnancy. We have a change to our breast size because of progesterone. Kind of get that letting in of milk. Certainly, that in combination with nursing a child changes the density of the breast tissue long term. We talk about lactation. The breasts are going to be fully mature. Milk is going to be secreted. Cessation of that, basically the glands are going to return hopefully down to that pre-pregnancy state. And when we go through menopause, we have a little bit of adipose atrophy that occurs, a little bit of thinning of the tissue, so a little bit of waste to the fatty cells also. So we talk about the nipple and the areola area. So basically that will change over the course of a woman's life. Typically it will get a little bit larger. Certainly with pregnancy it's going to get a little bit darker. But you should have ducts. We typically have a little bit more ductal opening at the superior aspect of the areola than the inferior aspect. But you are going to have a little bit of drainage from the breast. This is not something that women appreciate, okay? But it's just like how your skin normally lubricates any type of pore, so to speak, so that you're not having chafage to that area. So there's these small punctate openings, but they should be tiny. Again, you should not have any drainage that you can actively see from the breast tissue itself. The arterial supply, we get it from lots of different places. But basically we've got large intercostal arteries that help, branches of the thoracoacromial artery that will come in and help support the breast tissue. In terms of, they have the external mammillary branch. You got to remember some of those branches in terms of, maybe I do it just when we talk about heart disease, and we talk about using some of those vessels to bypass into the heart. Certainly when we talk about the lima on the left side, we use that quite often to bypass into the heart. But the blood supply to the upper aspect of the breast is going to be 2 times that to the lower aspect of the breast. That becomes very important when we talk about mastitis a little bit later today. The venous drainage, so we're basically going to drain out to the superior vena cava via the axillary as well as the internal thoracic plexus. The lymphatic drainage is way, way complex of the breast tissue. Very important, basically you're going to drain all of the tissue. You know, we always talk about really looking at that, of the axillary lymph nodes. Kind of we're concerned about the ones that are on the side of that breast. Understand that there is pathways for it to cross the midline and for, say, the left breast to drain to the right side and the right breast to drain to the left side. So in theory, whenever you do a breast exam, even though you might find a mass on the right breast, certainly be very cognizant of appreciating both axillary areas because you could get contralateral drainage in terms of lymphatic, okay? And of course, that's of greatest importance when we talk about breast cancer. Nerve innervation, so there's tons of different nerves that go to this cutaneous aspect of the tissue itself. And certainly when we talk about any type of surgical intervention on the breast, there's additional nerves that are going to go up underneath the axillary area to the upper aspect, internal medial aspect of the arm, that most women will post any type of breast cancer surgery, augmentation surgery, will be numb in that area for quite some time. One of the big arteries, or big nerves that we worry about is the long thoracic nerve. And that's one that we specifically worry about more so with larger breast surgery, so mastectomy, for example. And it's going to be a division of C5 to C7. It's kind of part of that brachial plexus that kind of breaks off. The concern is that if we injure that, they will get winging of the scapula posteriorly. So if you actually have them push on a wall, one scapula won't be stabilized posteriorly, secondary to injury there. We get, again, that intercostal branch that's going to be the medial surface of the upper aspect of the arm, and quite often that is, it's a very small nerve. It's not like you can really see it. You know, truly when we talk about looking at nerves from an anatomical standpoint, I describe a lot of stuff like food, you know. It looks like linguine, you know, but that nerve looks like angel hair pasta. So it's very, very small. You can certainly bifurcate or dissect through that unknowingly and subsequently cause numbness to that medial aspect of the arm. So you guys went over this, right? We communicate with the patient, we drape her, we open it down the front, we warm our hands, we make sure that we tell her exactly what we're doing. We only expose one breast at a time, you know, make her comfortable, all that kind of good stuff. So we want to obtain a good breast history. Certainly because we want to obtain a good breast history, we want to know a good menstrual cycle. Does she always have this type of tenderness or maybe this little lump at this point in her cycle? Most women will kind of know what lumps and bumps are normal to them throughout their menstrual phase. But you want to make sure that if they have any history of breast masses that have been there forever, most women will say, if they come in and they are concerned about breast cancer, I've got this bump and that bump, and those have always been the same. This is the one that's different, okay? Even just normally washing themselves, they kind of know which one is abnormal for them. Any nipple discharge, we want to know if it's bilateral or unilateral, the color, consistency of it, how long it's been there, if it's foul smelling, all that kind of good stuff. And any breast disease, if they have any hyperplasia, certainly if they have dense breasts, so you worry about that more so with women who've never been pregnant and never breastfed, because that certainly doesn't allow the construct of the breast tissue to change over time. And certainly if there's any personal history of breast cancer. So for most patients, when we talk about the history, we want to know when they started their period, and these factors all go directly to risk of breast cancer long term. And when we talk about menarche occurring before the age of 12, or menopause, true menopause, again, cessation of menstrual cycles for a year, occurring after the age of 55, the concern is that you have had estrogen in your system for a longer period of time. That's what it gets down to, okay? Family history, if you gave birth after the age of 35 or you've never had birth, basically if you gave birth after the age of 35, you might as well have not had kids, as it relates to the risk for breast cancer long term. Family history of breast cancer, they only care really about first-degree relatives. So it doesn't really matter if your aunt had breast cancer. It matters if your mother, your sister, or your grandmother had breast cancer in terms of the factor. Menopausal status, was the breast cancer unilateral or bilateral? Date of their last mammogram, any history of biopsy, and have they required to have, were you the kind of woman that got called back to have additional studies done on that breast? Were you the kind of woman that got called back to have an ultrasound done on that mass? So that plays into your concern for breast cancer long term. So we talk about the Gale score, which is also called the Breast Cancer Risk Assessment Score. I think we've talked about this before. Yes, ma'am?
Just real quick, when you said that the factors go directly to the risk of breast cancer, was it that whole slide or just the menstrual?
The whole slide.
Okay.
Whole slide. Okay. And that ties directly to the Gale score. Okay. So basically all of those things factor in. You can go to this website and basically you can punch in all your numbers as long as you're over the age of 35 and it'll give you a number. This is your risk of breast cancer in the next year. This is your lifetime risk of breast cancer. And that's what we would use that for. And live birth. Ooh, key, live birth. If they've had 5 miscarriages, that doesn't count. If their first live birth was after the age of 35, that's what they want to know. So if you've been able to get pregnant, it doesn't really matter. You had to deliver a child. Okay, that's what's going to help to decrease the risk for breast cancer long term. When we talk about breast exam, again, we're looking at the contour of the breast, the symmetry of the breast, knowing that most women are a little asymmetrical, but there shouldn't be gross disparity of one breast to the other. It happens on occasion, but that's not the norm. Certainly we want to look at the nipples. We want to make sure there's no retraction of the nipples. Retraction of the nipples, always bad, always bad. Boys or girls, always bad. Any skin changes. If there's any dimpling to the skin, any retraction to the skin, because truly when we see retraction to the breast tissue, it's because something is pulling that skin down, and typically it's tacking it down to the chest wall. That's bad, also bad, okay? Any inflammatory process. So certainly you would look at this woman and you'd be like, oh, maybe that's just cellulitis. I'm just going to give you some antibiotics. It's not cellulitis, okay? We'll talk about that today. So you want to look with their breasts at the side, okay? And I know you guys, and then leaning forward and arms overhead. And the reason for that is if there is some retraction to the tissue that's not grossly apparent when the arms are down, then having them pull their arms over their head or having them lean forward will allow you to see that, okay? The other thing that you can do is you basically have them put their hands on their hips and push in. And sometimes if they have truly a tumor there that's attached to the muscle, that will help to dimple that tissue back. And that way you can kind of find that. Understanding that when a woman has very pendulous breasts, sometimes it's really, really hard to get a detailed breast exam on these women. So those maneuvers will certainly help. So you want to look for any adenopathy. We're certainly looking primarily at the axillary area. But you want to feel supra and infraclavicular as well. We want to assess all 4 quadrants plus the tail of the breast. And when we talk about the breast tissue, it's really talking like how we talk about the vaginal area. Bartholin scans are at 4 o'clock and 8 o'clock. When you talk about a breast tumor or breast mass, it's at 2 o'clock on the left breast. Everybody knows that 2 o'clock on the left breast exactly where that is because you're doing it as you would a face of a clock. Okay. The nipples, if there's any discharge, squeezing the nipple to produce it is not a good prognostic indicator for breast cancer in terms of, yes?
When you're palpating the tail end, is there anything you do to differentiate between a lymph node or a mass?
No, your lymph nodes are going to feel, your lymph nodes shouldn't, again, they shouldn't be more than a centimeter, and so they're going to feel a little bit more like a lima bean. I know I'm using lots of food references today. But you won't be able to delineate, and usually your axillary lymph nodes are going to be way up in the armpit, whereas the tail of Spence is going to be more anterior. Okay, so it's just, you would go to location. But when we talk about nipples, and not to kind of to tell you a bad story, when we do neurosurgery, we used to always, for noxious stimuli, one thing we always used to do was we used to twist the nipple. If somebody was sedated and we didn't know if they were, just not listening to us or not able to wake up, we would twist the nipple. Or you do a sternal rub, Well, you rub the sternum so much that a lot of times patients would end up with a nice bruise there. I never did it, but I know of a resident that basically twisted the nipple so much that it avulsed off because it kept coming back in day after day after day and twisting the nipple. I'm not gonna like demonstrate it on somebody. That's
So I'm saying, like, when you know, like,
that it becomes necrotic. You would hope you would. So, all right. So when we talk about palpation of the breast tissue, you just want to make sure that you. Some people do it in a circular fashion. Some people do it in up and down fashion. Whatever you do, you cover the entire geography or map of the breast, and you do it the same way every time. Okay? You get in your routine. You got to make sure you cover all of the tissue. And you typically use the 3 fingers in a hand. Okay? Again, warming your hands. Usually those fingers have better, these 3 fingers actually, but you use these 3 fingers, but these ones have better tactile sensation in terms of the motor strip and the sensory strip of the brain. But again, you want to go up and down, you want to go over the nipple, and you want to make sure that you're palpating all the structures. Go all the way to the midline, okay, go all the way to the sternum, cover one breast, and then go for the other breast. So again, use 3 fingers, use the pads of your fingers. You can use light, medium, and deep palpation, kind of just how you would palpate the abdomen. You want to make sure, can you feel it on light palpation? Most of them you can't. Most of them are pretty deep. And so most of them you have to feel a little bit deeper. Again, we'll talk about most breast issues aren't painful. Most bad breast issues, I should say, aren't painful. Okay. So this is kind of a notation for a breast exam, normal versus abnormal. Again, you're using the clock to specify what you're feeling and saying how far it is from the areola or from the nipple line itself. Okay, that just kind of gives everybody an indication. Remembering, if you're doing this an abnormal exam, the next person you're referring them on to is potentially a radiologist and ultrasonographer. They want to go with that ultrasound right to the point. Okay, so don't have them looking all over the place. Tell them what you felt. So again, in terms of looking at the breast like it's a clock, we talked about the tail of Spence, but this is basically the occurrence of breast cancers that we appreciate on women, the vast majority of which are going to be in the upper outer quadrant of the breast, okay? Essentially that 9 o'clock to 12 o'clock aspect. Or if you're talking on the left breast, it's going to be 12 o'clock to 3 o'clock, okay? Because we're going thanks for the clock. So when we talk about mastectomy, for special circumstances, we want to make sure that we palpate the scar. Look at different scars, kind of old school scars for mastectomy are much, much different than the ones that we do now. But you want to make sure you palpate the scar and palpate the chest wall. Half the time, if they had a truly radical mastectomy, the overlying chest wall muscle has been removed. Pectoralis muscle's gone. So what you might be feeling there is basically the rib cage. Okay, but you want to make sure that you're not feeling anything abnormal. Look for any lymphedema in the ipsilateral arm, because for those patients, they've typically had some lymph nodes removed. And although if you only take out a couple of lymph nodes, your risk of lymphedema is very, very low, it can still happen. It's down to like 1 to 2% if you're only taking out a few lymph nodes, but still it can happen for that woman. So go ahead and check her hand. And of course, always, she'll never have a blood draw, and she'll never have a blood pressure taken in that arm because we've changed the construct of that lymphatic drainage. Augmentation, so basically the breast tissue should be overlying the implant. Some implants are done beneath the muscles, some not. It just depends, but the breast tissue should be in front of it. So typically you can still palpate abnormalities there, okay? Reconstruction or reduction, again, always palpate the scar line. Always know that some women just basically keloid worse than others. So some women form scar tissue worse than others, okay? Breast pain. So when we talk about actual breast pain, pretty common complaint. The vast majority of which never end up having breast cancer. Okay, so truly if somebody says my breasts hurt, in all likelihood they're talking about a benign pathology, which is good. Under the age of 35, it's pretty benign. And you want to look at what other stuff they're doing in their life. If they're doing a lot of this, yes, tell them to cut that out. That will typically help with breast pain, okay? Caffeine directly is derived to like fibrocystic changes in the breast, so just, have them cut down. They don't have to cut it out, just have them cut it down, okay? So you want to know the duration, the location of the pain, if they had any associated trauma to the area. You certainly want to know even about remote trauma. If they had a car accident and they had seatbelt injury to that breast, truly if it was a hematoma, God bless you, and it was 2 years ago, well, that should be better by now. If they're still having breast pain, we need to be concerned, okay? Any associated lumps or certainly any associated nipple discharge. So the cause most likely is typically menstrual related. Some women, remember those PMS symptoms. Their breasts will become a little bit tender. They may feel like their breast tissue is a little bit more swollen. So again, typically non-steroidal anti-inflammatories, Midol, usually is enough to help treat these patients. Costochondritis, so usually costochondritis is really, really bad coughing can cause it.